I'm very pleased to be joined by my co-chair, Mi Ji Lee. We both enjoy working on the Education Subcommittee of the International Headache Society. So we are going to kick right off, but the first thing for me to do is, of course, to introduce our first speaker. Professor Richard Stark from the Alfred Hospital and Monash University in Melbourne is a great inspiration and mentor to me. He's the past president of the Australian New Zealand Headache Society, very active currently in the World Federation of Neurology, and has been equally important in the Australian New Zealand Association of Neurology previously. He's adjunct clinical professor in the Department of Neuroscience and neurologist at the Alfred Hospital with a keen interest in headache. It's now the largest centre in headache in Australia, and many young Australian headache specialists have relied on being trained there. So he's been dutifully awarded multiple things, including the most prestigious Australian awards with the Graham Robertson Award for Services to Neuroscience and ANZAN, the ANZAN Medal for Services to Neurology, and also the Noshir Wadia Orator, as well as an Order of Australia. So I couldn't be more pleased than introducing Richard Stark to talk on this very practical topic. Thanks, Richard.
Thanks very much, Bronwyn. I hope everyone can hear me, and I apologise that you're not seeing me live at the moment, but I think our technical glitches have managed to turn my camera off. But I'm hoping everyone can see my slides. So I've been asked to talk about primary and secondary headaches, and those are some disclosures. So, I mean, it's obvious why we need to distinguish between primary and secondary headaches. We don't want to misdiagnose and treat patients incorrectly. And by definition, secondary headaches have got a cause which we need to address. But it seems like a fairly clear distinction, but there are some conditions that are on the borderland between primary and secondary headaches where we need to be particularly careful. And there's another more practical point, that as migraine treatments become more specific and more effective, we need to know which conditions that might not be defined as migraine but resemble migraine may respond to such treatments and which will not. So there's sort of a new way of really thinking about primary and secondary headaches now in terms of practical considerations. So what I'm really going to talk about is just a few comments about primary headaches in general, then some comments about secondary headaches in general, some practical tips about secondary headaches that can mimic migraine, which we don't want to miss, and then really just open the idea of, are there some primary headaches, things that we define as primary, that are really secondary, and can some secondary headaches actually transform into migraine? So obviously it's important to be accurate diagnostically. It directs us to appropriate investigations and treatment, and it's necessary for sensible research. But it is frustrating that the diagnosis of migraine and other primary headaches really depend on subjective information. We rely on the history that the patient's given us, and of course the ICHD classification is based on expert opinion rather than objective biomarkers. Now, of course, they are genuine experts, but nevertheless, it would be nice to have a clear-cut indication of what the cause of these headaches. So if you look at ICHD3, there are the three big areas of primary headaches. That's migraine, tension-type headaches, and the trigeminal autonomic cephalalgias. But there are a number of other, if you like, minor categories of primary headache listed, and they include the ones that I've put on the screen there. And some of those are, to a degree, problematic and may, in fact, represent secondary headaches. On top of that, it's important to remember that patients can have two primary headache disorders. And, for example, we very often will see migraine coexisting with other headache types. Very common for it to coexist with primary stabbing headache, or what we used to call ice pick pains, or with nummular headache. And I think actually probably not often recognised, but hypnic headache may coexist with migraine. I've certainly had patients who have been surprised to discover that the headaches that wake them in the middle of the night respond to having a coffee before bedtime, whereas they continue to have occasional migraines during the day. So when we see a patient in the clinic, the first question that often arises is, does this patient have migraine or a secondary headache? And it's important to remember that when we use the term migraine, we're talking about migraine attacks, but also migraine, the disorder. And migraine as a disorder is very common. The cumulative lifetime incidence has been estimated as being 43% for women, 18% for men. And I think it's probably higher than that if you count aura without headache in those aged over 50, because it's a very common phenomenon. Clearly, there are some people who are very susceptible and others have a mild tendency. And it's tempting to think that perhaps we all carry the capacity to have a migraine attack, but some of us have a greater susceptibility than others. Some require greater provocation than others. But it makes sense that the pathophysiological mechanism that produces migraine might be triggered by other disorders and might contribute to other headache syndromes. And so we do get this situation of overlapping phenotypes, and some of the secondary headaches do have a migrainous quality to them. So which conditions might be mistaken for migraine? Well, secondary headaches with migrainous features, sometimes primary headaches with migrainous features, so that there are some of those. And there are other neurological disorders that produce transient dysfunction with similarity to aura, and they can be diagnostically difficult. So first of all, to deal with secondary headaches presenting like migraine, we're all aware of looking for red flags. I think SNOOP4 is a very good way of doing this. David Dodick produced this mnemonic, and it's very helpful. But it's important to remember that patients who have migraine aren't immune from other conditions. And we really need to be tuned into patients with migraine reporting a changed headache pattern that still may have migrainous features. And for example, patients who present with subarachnoid hemorrhage may have obviously abrupt onset of headache, but may have some features of migraine in their headache and have even been reported to respond to triptans on occasions. So, it's what we tell our students: be aware of first or worst headaches. And of course, be aware that normal imaging that the patient tells you about may simply mean a non-contrast CT and may not be that helpful. I won't spend a lot of time going through SNOOP4, but it is a good mnemonic because it directs you to the sorts of things you should be thinking about in a particular patient. So if they've got systemic symptoms or signs, it makes you think of things like systemic illness. If there's sudden onset, you think of thunderclap, headache, subarachnoid, RCVS, and so on. And I won't go through the rest. I think we all are aware of these things. There are some secondary headaches, though, that are particularly tricky, and they're mainly the ones where the imaging findings may be subtle. So low pressure headaches, AVMs, IIH, and cerebral venous thrombosis are ones that I think are probably worth particular attention. Just be aware that low pressure headache from spinal leak may not always be postural. It may start as a postural headache, but then evolve into a non-postural one. The imaging findings may be subtle, especially if contrast is not given, and slightly low-lying tonsils might be called a Chiari malformation. And of course, late in the syndrome, the pattern can change, particularly if there's a spinal epidural cyst that develops, and you can then develop spinal symptoms more than headache, although the headache persists. Cerebral AVMs, of course, can present as very typical migraines. I think it is still helpful to listen for bruits, and I do that. And I think if someone has very stereotyped attacks, one should certainly consider imaging. And just as an aside, I've got a couple of patients who presented with migraine with aura, had orbital bruits, turned out to have an AVM, was dealt with surgically, but once it was fixed, their symptoms improved, but they continued to have headaches. They continued to have migrainous headaches, and in fact, the headaches behaved like migraine and responded to treatment like migraine. So it's like the secondary headache then converted into a migraine pattern. Idiopathic intracranial hypertension can be difficult to diagnose. We obviously suspect that in obese young women who have got recent onset headache, especially if they've got visual symptoms, and we confirm it with CSF pressure. But we are all aware that headache with migrainous features may then persist in these patients, even though the ICP has been normalised. Cerebral venous thrombosis, I think we're probably all tuned into this, but we have to remember it, especially in certain circumstances during pregnancy. And of course, in Australia, we had a lot of patients vaccinated for COVID with AstraZeneca, and a number of those did get venous thrombosis, but even more of them got aggravation of their migraine, read about cerebral venous thrombosis and were worried about it and would come in for attention. So I just want to change tack a little bit and say, are some of the primary headaches that we see really secondary headaches? Now, I know that Shuu-Jiun is going to talk about new daily persistent headache in more detail, and I won't really address that. I suspect that Mi Ji may be talking a little bit about headache with sexual activity as well, but I will mention that. And the other one just to talk about is cough headache. Just be aware that headache phenotypes, we have the ICHD3 approach where the primary headaches are defined on the left of the slide there, but it's true that secondary headaches can resemble migraine, they can resemble tension type headache. People with post-viral headaches often present as new daily persistent headache, and sometimes even TACs or thunderclap can be mimicked. So I think it is helpful to think of these phenotypes when we're looking at secondary headaches. Now, Shuu-Jiun and his group have written a very nice paper about headache associated with sexual activity. And because I think Mi Ji may mention this later, I'll go through this very quickly. But the point about this is that primary headache with sexual activity, the most common form of that is orgasmic. It tends to be explosive, instantaneous in onset. And so you'd think that sounds very much like RCVS. And indeed, the way it behaves, tending to be present recurrently over a few weeks and then to settle, is again similar to RCVS. So it's tempting to think that maybe some of these cases are a version of RCVS. And indeed, that's what turned out when Shuu-Jiun's group looked at this in detail. They looked at 30 patients who had headache with sexual activity. And when they looked very carefully, they managed to find evidence of RCVS in a good number of these. So I think it is true that probably many patients with so-called primary sex headache do have a form of RCVS. And there are some images from it. Cough headaches, another case in point, perhaps a little bit different. Just as a case example, this is a true case. A 72-year-old man came to me, previously not prone to headache at all, and he gave a 3-month history of headache occurring with coughing, sneezing or stooping. Moderate to severe, lasting up to 10 minutes, severe for a minute and then waning progressively. And he was putting up with it until he got a nasty cold and was coughing all the time, and it really became much less tolerable. So the question there is this primary cough headache, or does he have a secondary cause, foramen magnum lesion or a Chiari or something of that sort? So how to investigate? MRI brain and cervical spine, looking particularly at foramen magnum, and you might think of treating him with indomethacin, which is the usual treatment for primary cough headache. And of course, if he had a Chiari malformation, this is what we might see with evidence of a very tight foramen magnum, the tonsils down, and you can imagine that it would be difficult to equilibrate pressures between brain and spine. So this is what my patient actually had, and you'll see that it's not quite so tight, but he did have a large basilar artery, and in fact he had a very ectatic basilar artery which was looping around and meant that there was very little space at the foramen magnum. So the question really was, do we call him a primary or a secondary cough headache? Cough headache is typically caused by coughing or Valsalva, and it gives this history of abrupt in onset and then waning over a period of time, sometimes pulsatile. And we're able to identify an obstruction in about 40% of cases. And we know that it's probably caused by failure of intracranial and spinal pressures to equilibrate immediately after coughing or straining. And so obviously we do have to image the foramen magnum, but it does raise the question whether some patients that we call primary cough headache may actually have radiologically inapparent obstructions at the foramen magnum. And I've certainly seen two cases like this, one where a previous surgical procedure was done, and although it didn't look obstructed, a surgeon intervened and was able to clear some adhesions and improve the cough headache. And another patient who'd not had previous surgery, where again a surgeon was persuaded to go and have a look and actually cleared some arachnoid webs that were causing obstruction. So it may be that some of the primary cough headaches are indeed secondary. There's been a paper that looks at the differences between primary and secondary cough headache, and those who are interested can look at that in more detail. And finally, can some secondary headaches transform into migraine? And the sorts of things I'm talking about here is a patient with IIH who loses weight and is treated with acetazolamide. Their papilledema gets better. You can even do their CSF pressures again, and that normalises. But they keep on having headaches, which have migrainous features. And sometimes these patients will say, look, I know you say my pressure's down, but I don't believe it's down. I need a shunt. Now, I think we now understand that sometimes having IIH like this can trigger a sequence of events that provokes the development of migraine or the persistence of migraine, which can be very difficult to manage. So that's a scenario we see. Patients with mild head injury can get migrainous headaches, which then persist. And I know Henrik Schütz has written about this. He's been important in setting this meeting up. And I think there is actually a forthcoming webinar that will address this. But even patients with whiplash injuries can develop migraine, which persists after the neck you would think had improved. And patients with TMJ dysfunction can develop ongoing migrainous headaches. And of course, recently we've seen a lot of patients with COVID and other viral infections who've had perhaps occasional migraines in the past, but have much more troublesome headaches after the viral infection. So the question is, do secondary headaches occur in this way, or should we call them migraine that's been aggravated or triggered by something else? And that may be a practical issue as well as a semantic one, because in some countries, in Australia, for example, CGRP antibodies and botulinum toxin therapy are funded specifically for migraine, but not for secondary headaches. And so, it is important to make the distinction so that patients can be treated appropriately. I think it's probably true that there are many potential triggers or aggravating factors in individuals who have some susceptibility to migraine, and that really any pain around the head and neck can be a potent migraine trigger. And I think it can be a trigger not just for the time being, but can produce a rolling pattern, a chain reaction that produces ongoing headache. So obviously, if this situation occurs, you treat the underlying cause, but it's important also to treat the migraine. And it's interesting, Alex Sinclair, who sees a lot of IIH patients, has started treating her patients with persistent headache after IIH with CGRP antibodies, and has anecdotally reported that it can be very helpful in those patients. So it is behaving a bit like migraine. Again, it will be a point of discussion in a future webinar, so I won't spend too much on this, but post-traumatic headache typically resolves within 6 to 12 months after injury, but can persist longer. again, Shuu-Jiun's group have done some work on this and have found that the phenotype is quite often tension-type headache, but also quite often migraine. And I think there's another study from Ashina and others, and I think Henrik was involved in this, where the most common phenotype was chronic migraine. This raises the question of how you treat these patients. They often do respond to some extent to migraine treatments, but not as well as patients with standard migraine do. So there were half of the patients who felt that triptans were effective to a degree, and some patients found some benefit from preventive treatments that were used for migraine, but again, a smaller proportion than you'd expect for migraine. What about bruxism? There's no doubt that treating the patients who just have painful jaws from bruxism will get benefit from treatment with Botox, but it's very common that we see patients who develop this and have a susceptibility to migraine, and it makes their migraine worse. And we then treat their migraine, and it's certainly a common situation in my practice that patients who are treated with migraine who have bruxism as well benefit from Botox in the migraine protocol, but with some additional Botox in the masseters to help with that aspect of their condition. What about post-viral headaches? Again, there's been a lot of work done from Spain and from elsewhere looking at the patterns of post-COVID headache, for example. And it's true that there is a group of patients where it really looks like just an aggravation of migraine, but there's a group of patients who have headaches that are less migrainous. And generally, the more migrainous it is, the more likely it is to respond to migraine-type treatments, both triptans and prophylaxis. So the takeaway points from what I'm saying is primary headaches, migraine, tension-type headache and TACs are not contentious, but there are some other primary headache disorders that are not quite so well delineated. Secondary headaches can have migrainous features. Remember SNP4, beware of some of the particularly tricky ones. And I've just raised the question that some of the primary headaches, that some of the conditions we currently regard as primary headaches may in fact have an underlying cause and may at some time in the future be reclassified as secondary. Can secondary headaches evolve into migraine? I believe they can, and I think this does have some implications for treatment, which are very practical these days now that we've got more specific treatments for migraine. So with that, I shall end, and I know we're having some discussion after all three speakers. So thanks for your attention.
Thank you, Richard. The next speaker is Dr. Shuu-Jiun Wang. As all of you know, Dr. Wang is a leading neurologist and extinguished headache researcher in our region. He's a chair professor and vice dean of College of Medicine and director of Brain Research Center in National Yangming Chao Tung University and director of the Neurological Institute in Taipei Veterans General Hospital. He was the chair of the Asian Regional Consortium of Headache and the founding president of the Taiwan Headache Society. He's an associate editor of major headache journals, including Cephalalgia and Journal of Headache Pain. Dr. Wang was awarded by the American Academy of Neurology, the American Headache Society, the European Headache Society, and the Migraine Trust. Actually, he's a talented speaker. His talks are always full of humor and knowledge. Today, he'll give us a talk about new daily persistent headache, which is very challenging to clinicians as well as patients. The title of his talk is New Daily Persistent Headache a Primary or Secondary Disorder? Before having his talk, please note that you can use the Q&A function for any questions you may have. Dr. Wang, please.
Thank you, Mi Ji, and I will share my slide. Can you see my slides?
Yes, we can.
Okay, thank you. Thank you, Mi Ji, for her warm introduction. Today, my talk is that New Delhi persistent headache a primary or secondary headache? I will show you 3 cases. All of them have chronic persistent headache since a specific day. The first one is a 52-year-old woman with persistent headache, as she was infected with COVID. We just heard Richard talking about the post-COVID headache. The second case is a 36-year-old man with RCVS. We also just heard about it, and his background headache that never subsided. The third one is a 43-year-old woman with side lock orbital headache and with tearing and restlessness, and all of them are responsive to indomethacin. So you may think about the diagnosis, and we will come back later. New Delhi persistent headache is a rare headache disorder, probably not that rare. The 1-year prevalence of New Delhi in community, studied by Spanish doctors in the general population, is about 0.1%. And in Norway study, age 30 to 44, the prevalence is about 0.03%. This is really rare. But based on the hospital-based studies, especially the tertiary headache centers, in the pediatric groups with chronic daily headache, that means you have 15 days per month and rather than 3 months. The chance is about 0.9 to 35%. But for the adults, it's a little less. It's about 2.5% to 10%. I think it's around 10% for New Delhi persistent headache in tertiary headache center among the chronic daily headache patients. The diagnosis of New Delhi persistent headache was first described 1986, and the second year, 1987, a study found there's a link between New Delhi persistent headache with EBV infection, because they show the IgG antibodies to EBV antigen, like early antigen or the viral capsule antigen. They see the higher levels compared to the healthy controls. And I will show you a very simple diagram to make sure understand the diagnosis of New Delhi persistent headache easily. For the headache, as you know, episodic migraine and episodic tension headache. The headache is like this pattern. But for the cluster headache, you can see the clustering of the attacks, especially for the episodic cluster headache. But for the New Delhi persistent headache, it happens just one day. And based on the ICH, you have to remember the date of onset. Like today, I just saw a patient who told me exactly the date that she had a persistent headache after the date. So this is very important, because if you cannot date the date, probably the diagnosis has to be questioned. But the Delhi persistent headache is very great for the patients, and with a very severe impact on their daily lives. You can see the picture, and also they have to give up their routine, and their life never normal anymore, and their life, the joy of living is robbed. And also sometimes they will have some suicidal ideation. 1994, Dr. Silverstein and Dr. Lipton and Dr. Solomon, they propose a diagnostic criteria for New Delhi persistent headache. Probably this is the first diagnostic criteria. But in this diagnostic criteria, persistent headache is not that important, because it's only asked for more than 4 hours per day. But right now, since the diagnosis is called New Delhi persistent, probably persistent or constant is very important. And at that time, the migraine, the headache features are not asked for, and but most important is the acute onset within 3 days, then become constant. But in the 2004 ICH-V2, the diagnosis criteria becomes in this way: it still has to be more than 3 months. and has to be daily and unremitting from the third day, from the onset to within 30 days to become persistent. And the most important at that time, non-migrainous headache is suggested without very severe accompanying symptom like migraine. However, in our study just published several years later, we found the strict ICHD2 criteria probably not that right, because we found most patients, they have migrainous features. And we also found that migrainous features, New Delhi persistent headache, have higher pain intensity, higher depression level, higher MIDA score, and also lower quality of life scale. As you can see, the blue bar is the migrainous features, New Delhi persistent headache. The red bar is the so-called tension type. That is called the strict form. And you can see the blue bar is almost similar as chronic migraine. The blue bar is almost similar to chronic migraine. So I think the patients with migrainous features with New Delhi persistent headache, their severity is very similar to chronic migraine. And we also found two prognostic factors. One is if you treat the patients earlier, probably they can have better outcome. And also we found migrainous New Delhi persistent headache poorer outcome. In 2018, we know the New Delhi persistent headache changed because of the symptoms are no longer tension type headache, and migrainous features can be accepted, and they have to be unremitting within 24 hours, and they have to remember the date, which is sometimes very difficult. But you have to ask. And tension type headache no longer needed. And also they provide two types of subtypes. One is self-limiting. The second one is refractory subtypes, because they found some patients are very intractable to treatments. One very big study just published last year. I think this is a very good study, published by Professor Everts in the Headache Journal. This is completely his cohort of and the retrospective study. But in this study, you have to remember not persistent headache, not constant headache, it's just greater than 4 hours per day. But I think it's very similar to the New Delhi persistent headache, as we know. We can find very interesting features. The first one is their age is about 40, and most patients are female, and you can see side lock about 8%. And thunderclap had an onset with about 3%. And interestingly, visual aura about 8%. And more severe pain with migrainous features, and the migrainous features subtype are more common. It's about 80%. And the patients are very refractory. The relapsing remitting 2%, self-limiting only 4%. And they also found thunderclap had an onset with a very good response. However, they don't repeat our study. They found there's no differences in the refractory headache between migrainous feature and tension type features. Also, a recent studies on pediatric New Delhi persistent headache. We have to remember one thing: that pediatric New Delhi persistent headache is much more common than to adult New Delhi persistent headache in the CDH groups. And the two large hospital-based studies show. One is 200 and the other one is 155. You can see the age is about middle school age, female predominant, and very, very common for the total population and for the chronic daily headache. And they have very common migrainous features, and about 20 and 30% they have the medication overuse headache, and the most important, very refractory. 30% they fail more than one preventive, and 56% fail about more than one avoided treatments. So they also found New Delhi persistent headache and chronic migraine are very difficult to distinguish, because therefore, they consider new Delhi persistent headache probably a subtype of chronic migraine. I think especially for the pediatric or adolescent patients, probably you have to ask more exactly about the onset of their headache. Because in my experience, sometimes if you ask directly, you will know some patients probably they are more likely new Delhi persistent headache, and you will know probably these patients are more difficult to treat, especially in the adolescent groups. And they also found some prognostic factors. The pediatric patients with new Delhi persistent headache are more difficult to treat, and especially those without treatments and also those without triggers. How about the triggers? As we know that the first studies published, they found a systemic infection with EBV virus. And also we found many patients with stressful life events. They tell you the mother admission or they have terrible life events. So I think this is very common in your daily practice. And recently there are several identified triggers. First one, I think, is a COVID-19. And also we found the vaccination. We found vaccination is also a trigger. And also this is the cervicogenic orange, because they also found some patients after the surgical procedures that involved the intubation, they consider probably cervicogenic orange. And also some single Valsalva maneuver. And they also found this is very important for the treatment, because they found if the patient have Valsalva maneuver events, probably they are more likely to respond to diamox, or because they consider this is abnormal reset of cell pressure or distribution. This is a very interesting paper published by the Ross, and he mentioned about the 3T of the new Delhi persistent headache, because the three triggers probably they can use to treat the patients. The first one is post-infectious. IV methylprednisolone probably helpful, but Valsalva maneuver, acetaminophen can be used, just as I mentioned earlier. And lumbar position, with the head down position tilt, with 1 to 2 minutes, the headache becomes severe. Probably you can consider about the CSF pressure, and CSF volume can be related to the headache. And also the thunderclap headache as the beginning, because this has been considered as the more benign new Delhi persistent headache. Probably they can be used in monitoring, and probably these patients can give us a hint that vasoconstriction might be a trigger of the new Delhi persistent headache. However, new Delhi persistent headache, the patients have higher anxiety and depression compared to chronic low back pain. So their mood, their emotion has to be taken care of when you are treating these patients. However, the pathophysiology or pathogenesis for new Delhi persistent headache are very limited based on research. And this several years ago, they found that probably neuroinflammation plays a role, because they check the CSF, but not serum. TNF alpha, they found a higher level in patients with new Delhi. And this is also very similar in those with refractory chronic migraine. I found a study they are going to be done by Richard Lipton. They tried to understand more about the biomarkers, including the new Delhi persistent headache, in addition to chronic migraine or hemicranial continuum. Unfortunately, the study was terminated due to COVID-19. I hope that this kind of study can be reopened, and more data are needed to understand these very rare and very difficult to treat patients. The randomized control trials are still very lacking for new Delhi persistent headache. We have to base on their migrainous feature or tension high features to give them empirical treatments. One single case, they provide the treatment response to Ivaxo, the venlafaxine. And very interesting, they give us a retrospective study with chart review in several cases. They found preamp protocol probably effective in some patients with New Delhi persistent headache. You can see 50% patients with reduction in headache frequency, and the 75% they have reduction in headache severity. Some patients they can be treated with nerve blocks, but only 3 patients, 2 out of the 3 with the response in elderly population. I like this study. This study is published by Jefferson Headache Center. They use ketamine. They use ketamine infusion to treat the patients. You know, the ketamine is a NMDA receptor antagonist. They use sub-anesthetic dosage. And they found acute responder is about 60%, and the sustained responder is about 30%. I think this is a very good study, and probably we have to adopt some their protocol in the future for those with intractable New Delhi persistent headache. How about the CGRP monoclonal antibody? I searched the one study with adolescents with refractory headache. About 10% of them are New Delhi persistent headache, and they found some significantly helpful. But unfortunately, New Delhi persistent headache was not reported separately. We don't know how much percentage are responded. So I would go back to the patients because they always have chronic persistent headache since a specific date. So how do you consider these patients after infection with COVID and with ICH-D3? You can find the headache attributed to systemic viral infection. So you can have New Delhi persistent headache, but you still can have so-called secondary headache. They are very arbitrary. And for the second case, I believe that you can give the diagnosis in New Delhi and also the persistent headache attributed to past RCVS. And then for the third case, they have the features are very similar to hemicranial continuum. So even though they are very similar to hemicranial continuum, they still very similar to the symptom of New Delhi persistent headache. So I think New Delhi persistent headache probably is a headache that just form between 2 diagnoses, primary and secondary. So I would say New Delhi persistent headache is probably not a disease entity. It can be considered as a syndrome with different heterogeneity, and probably we need a very good classification in the future. So I would suggest some future perspective. The first one, I think we have to establish the precise subtype classification based on their clinical phenotype and also predicted outcomes or any other clinical profiles. And we have to understand more about the pathophysiology. Probably we have to understand the biomarkers, genetic predisposition, and also the environmental factors. And the most importantly, since some patients are very, very intractable, especially for adolescents, I think we need to provide evidence-based treatments, high quality, and randomized control trials. And this is my last slide. With that, thank you for your attention. I would like to answer some questions after all 3 speakers are done. Thanks very much.
Thank you so much, Professor Wang. I'll get you to stop your screen share so Professor Lee can share her screen. And it's my great honour to introduce my co-chair as speaker now. I've really enjoyed encountering her at all our meetings prior to COVID. She had an astounding quantity and quality of work as a young neurologist and continues to broach everything with a passion and enthusiasm as well as expertise that I can't even try to equal. She's assistant professor of neurology at the Seoul National University College of Medicine in Korea. She's a neurologist, headache specialist and researcher at the Neurology Department of the Seoul National University Hospital. And she obtained her MD at the Sung Kyun Kwan University. Apologies for my pronunciation. She's had a 3-year fellowship in the field of stroke and headache, which is often common things to combine in Australia as well. And from 2017 to 2022, she's been a clinical assistant professor in the Samsung Medical Centre. She's moved to the Seoul National University from March 2022, and she's already authored more than 100 scientific papers in peer-reviewed journals and several book chapters. I particularly enjoy that she's often asking the research questions we encounter in clinical practice. Her main fields of research now involve migraine cluster headache, RCVS, and pressure-related headaches. So there was some peer pressure involved in me asking her and suggesting to her that she do this talk to follow on in this close link between the primary and the secondary headache disorders. So she's hoping to find some connection between migraine and stroke. That will be another webinar for another day at all the correct times. Thank you for your patience with tonight's evening, and do put those answers in the Q&A. I'll hand over right now. Thanks, Mi Ji.
Thank you, Bronnie, for the lovely introduction. My name is Mi Ji Lee, working in Seoul National Hospital in Seoul, Korea. And these are today's topics. First, I'll give you an overview of thunderclap headache and RCVS. So what is thunderclap headache? There is no single definition of thunderclap headache. Its intensity is usually, but not always, severe. The mode of onset is typically abrupt, with the time to peak intensity less than 1 minute. Duration is variable, but usually more than a few minutes. Too short-lasting headache, like a few seconds, should be differentiated from a stabbing headache. And there are no specific location and type of pain to define a thunderclap headache. Here you can see the potential causes of thunderclap headaches. Major differential diagnoses are highlighted in bold: subarachnoid hemorrhage, intracerebral and intraventricular hemorrhages can be diagnosed by brain CT and sometimes by lumbar puncture. However, there are much more causes that may present with normal CT and normal CSF findings. The major differential diagnoses include dissection of intracranial or extracranial arteries, symptomatic aneurysm with mass effect, reversible cerebral vasoconstriction syndrome, RCVS, cerebral venous thrombosis, and pituitary apoplexy. Subarachnoid hemorrhage is the most important cause of thunderclap headache. Non-contrast CT is a primary method of diagnosis, but its sensitivity decreases over time, particularly after 24 hours. If combined with lumbar puncture, a combination of negative CT and negative LP can be nearly 100% sensitive to exclude SAH at 12 hours to 2 weeks after onset. But not every time the LP is available, and when both the CT and LP are negative, we finally need MRI looking for other etiologies. Then what about performing MR initially? MR FLAIR and SWI imaging have high sensitivity for SAH, and if combined, they are nearly 100% sensitive. So the MRI can be an alternative to CT and LP. Another alternative is the combination of non-contrast CT and CT angiography. They can exclude aneurysmal SH with a 99.4% sensitivity. And what is RCVS? It indicates a group of disorders showing reversible stenosis in cerebral arteries, per the first definition in 2007. Now we define it as a combination of newly developed intracranial arterial stenosis, reversible course within 3 to 6 months, and by excluding other conditions, particularly vasospasm caused by SAH, arterial dissection, and vasculitis, because these conditions can meet the first and second criteria. RCVS can be idiopathic in many cases. However, certain conditions can precede to RCVS. Causes of RCVS include pregnancy, postpartum period, vasoactive drugs or substances, such as illicit drugs, sympathomimetics, migraine drugs such as Alvox and triptans, SSRIs, and other substances, including Ricolyce, ginseng, and so on, intracranial or cervical arterial dissection, vascular surgery or intervention involving the intracranial or extracranial arteries, systemic disorders that can heighten the systemic sympathetic activity, such as pheochromocytoma, and other conditions such as massive blood transfusion, EPO infusion, intravenous immunoglobulin, thrombotic conditions, and immunomodulators have been reported so far. Clinical manifestation of RCVS is mainly headache. It's typical abrupt and severe thunderclap in 95%, recurrent thunderclap in 85%, in some attacks triggered by typical precipitants such as defecation, and urination, physical exertion, swimming, emotional surge, coughing, bathing, showering, laughing, sexual activity, and bending in 87%. Some of these triggers are quite unique to RCVS, such as urination, bathing, and showering are not reported to cause any other conditions. And atypical cases with mild or no headaches have been reported so far. Radiological features, typical findings of RCVS is multiple segmental vasoconstriction and vasodilation, so-called string of beads appearance, and it can be found in 70 to 80% of patients. If present, it affects distal arteries first and then propagate to proximal arteries. We call this centripetal propagation, and it has been found in 50% of angiogram positive patients. Another typical finding is BBB breakdown. It is found in about half of patients, according to a recent collaborative study from Korea and Taiwan. It can be clearly demonstrated by delayed contrast-enhanced FLAIR imaging. Neurological complications of RCVS include focal neurological deficits, BP surge, seizure, cortical SH, ICH, PRESS, and ischemic stroke. The prevalence of neurological complications are highly variable between studies. This table summarizes the major characteristics of 5 large RCVS cohorts reported so far. I wouldn't go into details, but you can see that Taiwanese and Korean RCVS cohorts have mostly idiopathic RCVS and a very low rate of neurological complications. RCVS has a dynamic time course of symptoms. Thunderclap headaches usually recur during the first 1 to 3 weeks. ICH, SH, and PRESS occur only at first or second week after onset, while ischemic stroke occurs at second or third week. Radiological findings also dynamically change. Vasoconstriction severity is maximal at third week, which explains the delayed development of ischemic stroke. BBB breakdown peaks earlier than the peak of vasoconstriction, and this explains the early development of SH and PRESS. I think it is so important to understand the dynamic nature of RCVS, especially for the differential diagnosis. The definitive diagnosis of RCVS requires documentation of reversibility, so it takes several months. However, we should make an early tentative diagnosis to make a treatment plan, and it can be done by identifying the unique clinical radiological features of RCVS and differential diagnosis. For the radiological diagnosis, MRA is a preferred method, although its accuracy is not excellent for the distal arteries. CT angiography is much less sensitive. TFCA is now controversial, although it has many strengths, but it carries a risk of deterioration. Lumbar puncture is usually not required when aneurysmal SH is fully excluded. In case of a normal angiogram, I would recommend to repeat angiogram after a few days if possible. And if still negative, we can diagnose probable RCVS. Differential diagnosis can be made on clinical and radiological manifestations. And high resolution with more MRI and delayed contrast enhanced FLAIR imaging can help. This figure summarizes the diagnostic algorithm of RCVS. Let's move on to differentiating RCVS in patients with thunderclap headache and vasoconstriction. First, RCVS should be differentiated from vasospasm from aneurysmal SH. Which one do you think is RCVS? The left one, which involves distal ICA, was from a patient with aneurysmal SH, and the right one, affecting multifocal distal iris, was from an RCVS patient. The hemorrhage pattern is also different. Aneurysmal SH is mostly located in basal cisterns, in this case, sylvian fissure. In contrast, SH of RCVS predominantly occur in convexities. This table summarizes differential points between aneurysmal SH and RCVS. Hemorrhage patterns differ, as I said before. Vasoconstriction is maximum at the site of bleeding and correlates with the amount of hemorrhage in aneurysmal SH. In contrast, vasoconstriction of RCVS is multifocal and diffusely involved, usually more severe than the amount of SH. Mostly bilateral and distally located at first and then propagate to proximal arteries. In aneurysmal SH, vasoconstriction peaks several days after SH, while in RCVS complicated by SH, vasoconstriction is often already profound at SH onset. Otherwise, SH can develop after a few days or weeks. Headache from aneurysmal SH is not always thunderclap, and I feel like it's more persistent with a high severity than in RCVS. RCVS usually presents with thunderclap headache, and the thunderclap headaches are often self-limiting, recurrent, but there's no headache or only a mild headache between attacks. The number 2 differential diagnosis is PA-CNS, primary angiitis of the CNS. Vasoconstriction of the PA-CNS is not so severe and less metric, and segmental dilation is rare. Brain MRI is almost always abnormal in PA-CNS. In infarct is very common and frequently affects the deep gray matter and brainstem. Whereas in RCVS, infarcts are less common and deep structures are not frequently affected. Hemorrhages can occur in both conditions, but PRES is very rare in PA-CNS, while it is a major complication of RCVS. Headache in PA-CNS, it does not present with thunderclap headache. Its headache is usually gradual onset, dull, and progressive. In RCVS, thunderclap headache is the major presentation and typically recurrent. High-resolution reservoir MRI can have the differential diagnosis when available. The MGH group showed that the recurrent thunderclap headache alone is highly specific for RCVS against PA-CNS in their cohort, and even a single thunderclap headache has a high specificity. When combined with a normal brain MRI, FLAIR dot sign, border zone only infarct, and PRES, the specificity is nearly 100%, favoring the diagnosis of RCVS. These are common parenchymal imaging findings of PA-CNS and RCVS. Third one is arterial dissection. In case of single arterial stenosis and significant headache, it can be challenging to differentiate RCVS from arterial dissection. Actually, these two cases are nearly indistinguishable to me. Arterial dissection usually affects a single artery, while RCVS usually involves multiple arteries with sausageal string appearance. But sometimes RCVS can be seen only in one segmental stenosis. So in such cases, the high-resolution vessel wall MRI is often the only way to differentiate RCVS from dissection. RCVS-2 score was developed by the MGH group to distinguish RCVS from other vascular pathogens. A score of 5 or higher had 99% specificity and 90% sensitivity for RCVS. However, please note that this score was derived from a database of intracranial vascular pathogens, not from thunderclap headache database. So you can see that the recurrent or even a single thunderclap headache can score 5, which means all the thunderclap headaches with intracranial stenosis is RCVS, which doesn't make sense. But the green box here is, I think, rather valuable, which shows the intracranial carotid artery involvement is very rare in RCVS. I strongly agree with this, although we don't know the exact mechanism why intracranial carotid is spared in RCVS. Next, we'll move forward to cases with thunderclap headache without vasoconstriction. Angiogram negative RCVS can be diagnosed as probable RCVS based on the ICHD3. ICHD3 criteria require recurrent thunderclap headache and at least one attack triggered by typical precipitant and no recurrence of significant headaches after 1 month after onset. These criteria were validated by our group, but it's not a perfect criteria. Another way to identify RCVS is RCVS TCH score. Our group developed a prediction model of RCVS among patients with presenting thunderclap headache. We found the recurrent thunderclap headaches, female sex, multiple or single triggering factors compared to no triggers. BP surge are independently associated with RCVS, and the score of 8 or higher had a high specificity for RCVS. But please note that aneurysmal SH and meningitis should be excluded prior to the model application. This score worked better than RCVS-2 score, at least in patients with thunderclap headaches. After distinguishing probable RCVS, we can diagnose primary headache disorders. Primary cough headache is triggered only by coughing, straining, or Valsalva manure, and can have a very short duration, like a few seconds, with a very variable intensity, including moderate or mild. Primary exercise headache is triggered exclusively by exercise, and in most cases, it presents with a gradual onset, long duration, migraine-like headaches. Primary headache attributed to sexual activities can have gradual or thunderclap onset, severe intensity, and exploding nature. So its clinical presentation is somewhat similar with RCVS, and we think it can have vascular mechanisms similar to RCVS. Currently, the only differential point between probable RCVS and primary sexual headache is a clinical course. Recurrent thunderclap headaches, but monophasic course in about 1 month favors the diagnosis of probable RCVS. Primary thunderclap headache should be diagnosed as a last resort after excluding all the secondary and primary headache disorders. In summary, RCVS is a dynamic disorder that presents unique time courses of symptoms and radiological features. Unique preceding conditions, triggers, and BBB breakdown can support the diagnosis of RCVS. Differential diagnosis is important, especially for the early identification. So when vasoconstriction is present, vasospasm from SAH, vasculitis, and arterial dissection are major differentials. clinical manifestation, time course in brain MRI or high-resolution wall MRI can help. When vasoconstriction is absent, probable RCVS should be considered based on the ICD-83 or RCVS TCH score, and the other primary headaches can be diagnosed. Thank you for your attention, and I would love to take any questions or comments right after this talk at the discussion session. Thank you again.
Thanks so much. That was fantastic. The talk's all tied together very well. We'll just get Professor Wang's video on, and we'll start the question and answer. I'd encourage everyone to keep putting questions in the question and answer box, which is down at the bottom of the panel, rather than in the chat, which we will be checking. And all these talks will be on the International Headache Society Learning Centre in a couple of weeks for members. Apologies that the Zoom link said a different time to the advertised time, so we continued on and now have finished the talk. So we'll kick off with a question to Professor Stark, and then I'll let Professor Lee also ask some of the questions as my lovely co-chair. But Professor Stark, I thought this question was a great philosophical summary, essentially, of some of the aspects of your talk. And it's great to see the familiar names out there in the audience. The question was, should we take notes for the secondary headache phenotype of patients and put it in the diagnosis, such as secondary headache with migraine features due to trauma? And how about if we treat the secondary headache according to the headache features, but we also treat the underlying disease?
Thanks, Boronia. I agree with that approach. I must say I've always tended to take note of what the patient is describing in terms of their headache pattern, because I think it does give a clue as to what the underlying basis for it might be. But up until now, that's been something of an academic process, I guess. But it really does become a much more important clinical aspect now that we've got so many specific treatments available for migraine in particular. And it really does raise the question of whether some of these conditions that we've regarded as secondary headaches, and which are secondary headaches, but probably have overlap in their pathogenesis to migraine. So it is something that I certainly do. I note that it's a secondary headache, that it's caused by trauma or associated with neck injury or following a viral illness or something of that sort. But I think it really is important to note that it's migrainous in type. And certainly my experience has been that many of these patients who do have migrainous headaches do respond to migraine treatment, perhaps not as often as people with pure migraine do. So, we expect with modern treatments, the Botox and CGRPs for chronic migraine, to see the majority of patients respond well. Maybe patients in the sort of post-IIH or other situations with migrainous headaches, it's not quite such a high percentage, but it's certainly a proportion, and it's better than zero. So I think it's something that we really ought to be thinking about offering these patients. And of course, it's something we probably ought to be speaking to regulators about as well, because the rules about access to these sorts of agents are going to vary enormously from country to country and will depend on the detail. You're muted.
That old trick. Just making sure everything goes wrong. I can see Professor Wang nodding his head, so I'm going to use a co-chair discretionary and ask a second question in a row. I promise then I'll shut up. But there was a question that would it be possible that new daily persistent headache is a mode of transformation of migraine, because NDPH is so often like chronic migraine? You gave an elegant description of the tension type features initially described, but certainly in the response and all those things, I just think it ties in well. So what do you think about it as a mode of sudden transformation of migraine potentially?
Yeah, I think Currently, because we are diagnosis these patients by their clinical profile rather than by the underlying pathophysiology, which is probably very difficult to do. So I think they probably can consider as a transformation in certain patients, but not all of them. I would say that. And based on our studies, patients with new daily persistent headache with migrainous features are more difficult to treat than chronic migraine. If you can trace their history at the beginning, that they usually started with episodic migraine, then gradually to transform migraine or maybe chronic migraine. I think these patients are for certain portions they are easier to treat than new daily persistent headache with migrainous features. But I think currently since we are diagnosed patients based on their clinical profiles, probably some patients they can be considered in this mode of transformation, but not all of them needs to be understood more in the future.
Thank you, Dr. Wang. And there are several questions to Dr. Stark, and Dr. Mingju Wu asked the question: what's the best timing to take indomethacin if cough headache only lasts for a few seconds?
Yes, that's quite right. You can't respond to the cough headache by taking indomethacin. So patients who are getting very frequent cough headache and it's disabling for them will take indomethacin 3 times a day so that they've got some indomethacin on board all the time. So it's a relatively straightforward intervention, but of course we're all well aware that many patients don't tolerate indomethacin all that well. So it's great if it's tolerated and it works well. If I can head on with the cough headache, I saw there was another question there which really asked, do I believe that any cough headache is primary? And I think the answer to that is probably it is sometimes. And again, I think the details of the history are really, really important. If you get a typical history of absolutely abrupt onset headache, very severe initially, fades within 30 seconds, and then you get this slight pulsatile reduction over the next 2 or 3 minutes, it's very difficult to believe that that's anything but foramen magnum obstruction and changes in fluid transmission. And those patients, I really do have a sneaking suspicion that many of them will have radiologically inapparent obstructions at the foramen magnum. There are other patients that get cough headache. They cough, they get a bit of headache, and it fades off in a more gradual fashion, maybe over 20 minutes, half an hour, not the pulsatile pattern. And I think that's much more likely to be other factors, and maybe they've got sensitized vessels for some reason, and it's not related to foramen magnum level. I'd still image them, of course, but so I think there probably is a primary type of cough headache, but I suspect that probably many more than we believe of the patients that get that really typical clinical pattern of severe onset and then pulsatile reduction over a few minutes. I think many of those may turn out to have inapparent obstructions. And as I said, I was brave enough, at least in one patient, to ask a surgeon to explore. The patient was very insistent. He wasn't going to put up with it. He wasn't tolerating indomethacin. And in fact, we did get a good result in that case. But you have to be brave to ask a surgeon to do that, and you have to have a trusting surgeon as well.
That's really interesting that you notice the different clinical features between these differentiations. It's not just reliant on extensive investigation, and it probably flows quite nicely to asking Professor Lee a question about the RCVS. And I must say, I noticed that licorice and ginseng that are triggers for that are also triggers for migraine. So there is so much overlap in all the things we've been talking about tonight. But Do you have anything to add to that differentiation? Because you had a nice slide there where you talked about primary headache disorders, Professor Lee, and delineated the different clinical features that you see in your busy practice of how to differentiate that from being likely to be a thunderclap headache that you have to investigate.
Do you mean when to investigate extensive workups for thunderclap headaches, or how to differentiate thunderclap headaches from other types of headaches such as migraine?
Well, you mentioned the cough headaches and those things later on in your talk after you very clearly talk through the thunderclap headaches. And I think what we notice clinically is often quite relevant, isn't it, to how we then go on and investigate. It's a bit too broad a question probably. So I'm going to ask you some more specific questions then, because it sounds like there's a chance that this group could solve all the questions about RCVS. Henrique Winterschitz, who's online and chair of the Education Subcommittee, and we're very grateful to him for thinking about the Asian Pacific region and the time zones and topics, has asked a couple of questions, and they're really interesting. One is that the triggers, such as, you mentioned urination can be a trigger, which is not in any of our other headache disorders. How do we explain that? Is it because of the vessels are affected by the other triggers, or are there other mechanisms at play, in fact? And following on from that, he quite rightly noted that a lot of our headache disorders that we manage more commonly are considered to be painful during the vasodilation stage. So why are these vasoconstrictive headaches actually painful? So if you can sort that out, we've pretty much nailed it tonight of figuring out a big pathophysiological question. What do you think about those?
I think it's from the basic difference from cerebral circulation and systemic circulation, because cerebral circulation is regulated by many other factors. There are major 4 regulatory factors, including chemical, neuronal, and mechanical, such as blood pressure. And the last thing is autonomic regulation. But in physiological condition, there are much more higher influence from neuronal and chemical regulations, such as CO2, pH, and O2. And there are very minimal influence from autonomic regulation, such as systemic, sympathetic or parasympathetic influence. But I define RCVS as a disorder of broken regulatory mechanisms, like neuronal or chemical or mechanical. Then the other the last one, the autonomic regulatory mechanism is very atypically profound in the setting of RCVS. So very little alterations in sympathetic or parasympathetic tones from urination, bathing, showering can alter the cerebral vascular tones. So it can cause either vasodilation or either vasoconstriction. And the latter question is what is the pain mechanism of RCVS? So that was my question too. But I think I agree with Henrique that vasodilation is main mechanism of pain in RCVS. So there cannot be headache in patients with very severe vasoconstriction, but and sometimes SH or seizure, but there can be no headache in a patient. So that can be an answer, but I don't think the severity of vasoconstriction or vasodilation correlate with the severity or frequency of headaches. So that should be investigated in future, maybe by Dr. Wang.
Yeah, I appreciate it. But isn't that true that you often see the radiological changes lag behind the onset of the headache? in what you discover. So there's a lot of unanswered questions here. So perhaps we haven't answered all in this, but it certainly raises some interesting questions that our large populations in this region could probably lead towards answering, because these do occur in different frequencies in different populations. And we've got a great population for vasoconstriction in our region. I was going to ask, what was I going to ask actually? Yes, I was going to ask a question that was in the chat. Apologies to the panel. So because this is quite an important question, it's to all three of you, whoever wants to answer it. Are there any specific recommendations in all these topics of differentiating primary from secondary headaches and how we approach them, bottom up or top down cause or symptomatology, for children or elderly cases? Does the age of the cohort alter your advice and how you manage it and investigate it?
Well, I guess I'll start off. I'll do the easy bit. The thing that clearly is the case is that the prior probabilities are different according to the person's age. So that when we see someone developing a first headache in their 70s or 80s, it's much less likely to be migraine than it is in someone who's younger. And I think it is true that we do see different patterns of disease in patients at different ages. But I think the principles are the same. You take the history and you work out the phenotype and you look for underlying causes that might be the basis for the type of secondary headache that occurs at that age. So, I mean, we're all aware you look for giant cell arteritis in someone who's older. You wouldn't be looking for that in a 20-year-old. I have to confess that I don't see a lot of children, but there are no doubt specific conditions that one sees in children as well. And of course, we know that migraine behaves differently in children as well, so that there's a different phenotype. My general view would be take the history, but be aware of what's common at a particular age.
Richard, you have another question from Debbie. The question was if we can diagnose other primary headache in patients with migraine. And the next question was that what is the underlying pathophysiology?
Okay. Well, I mean, we certainly do sometimes make two separate primary headache diagnoses. And I think that the commonest one is idiopathic stabbing headache that we see in patients with migraine. It's not rare, and it's presumably there is some overlap in pathophysiology, sensitivity, pain thresholds, and so on. Certainly, I've been impressed that I see nummular headache in not a tiny number of patients that I see with migraine. Now, it may be because I'm seeing them often to inject them with Botox, and they then become very keen to identify areas of the scalp that they think are causing them trouble. But I can think of, it's probably something like 2 or 3% of the patients that I treat with Botox have identified at times during their course coin-shaped areas that have been unusually sensitive and have behaved separately from their migraines. And generally what I do is just put a bit of extra Botox into the area, and it often helps them. So I think those are clear headaches. As I mentioned, I think hypnic headache, the patients that I've had with both that and migraine, the two conditions have behaved independently in terms of responding to treatment. So the migraine responds to migraine treatment, the hypnic headache responds to having caffeine before bedtime. And if they leave off the caffeine, the hypnic headache comes back. If they leave off their migraine prophylaxis, the migraines come back. So I think they are two independent conditions that are occurring in these patients. I know both Shuu-Jiun and Mi Ji see lots and lots of patients as well, and I'd be interested to hear what their feelings are about that.
I think they agree unanimously with you. Okay, on to the next question. We're going to wrap it up soon, but there's a couple more questions. So Professor Wang, an obvious question. Some people might have missed it though, and it is a great question. Should we have clinical trials on new daily persistent headache? I think you gave us some clues as to how you'd organise them, but perhaps you'd like to tell us what we should be doing as a region and internationally.
Yes, I totally agree with this question, since randomized control trials are very lacking. In fact, it's still lacking for new daily persistent headache. And I also want to share a very important point is, since some patients with new daily, some patients do remit within like 6 months. So I would say, if we want to recruit patients properly, we have to ask for those with really intractable cases. And probably CGRP monoclonal antibody is a very good example that we can use in the future. Randomized control trial, if that not that easy, probably we can use open label trial. And at least we need to have some evidence for these patients. And in our hospital, we find some patients do respond, but not that as good as patients with chronic migraine, in my opinion. But this is a very good issue that we have to do, because these patients, especially certain of them, some patients of them are very intractable.
Yeah, I think we all agree with you there, and we've noticed the same things. At least they'd have a tiny placebo response in that group, which mars our studies of the perfect patients that are so commonly studied. I'm going to finish off the questions by posing two. Firstly, a diagnostic and then a management question to Mi Ji. So as far as diagnostics, do you find that there are many presenting with neck pain like we find in migraine patients? And the second question from a different person is, what do we do if the person doesn't respond to nimodipine with RCVS? What's the next management step after the gold standard of nimodipine?
Yeah, for the first question regarding neck pain, I don't think neck pain is quite a big complaint from patients with RCVS. How do you think, Dr. Wang? Are your patients complaining of neck pain?
Not that many, in my opinion, because usually many of them can complain, but they do complain neck pain. But mostly because I think the RCVS, the most common area is occipital, in my opinion. So they always say that it's just behind the head. But if the neck is the only place, probably is not that true, in my opinion.
If neck pain is quite profound, and that should be differentiated from neck rigidity from aneurysmal SH. So it can be a warning sign to me. And the next question regarding treatment, we have to distinguish if the patients still have recurrent thunderclap headaches, or they have persistent headache after thunderclap headache. So if a patient have recurrent thunderclap headache despite of oral nimodipine, I would increase the dose, shorten the interval. And if refractory, I would apply IV nimodipine in such case. But if a patient have a persistent pain after a single thunderclap headache or recurrent thunderclap headaches, I would apply some migraine preventives to treat chronic post-RCVS persistent headache. And What do you think, Dr. Wang?
Narrowing. I'm not sure. Do you do that, Mi Ji? Because I always consider narrowing, especially narrowing in Taiwan, can be used. I'm not sure in Korea probably the same. I'm not sure the same in Australia, because I think phenarizine is also effective for migraine, and we do find some patients with migraine, and also we also consider phenarizine is one type of calcium channel blockers. So I usually like to add phenarizine at the same time. I'm not sure if this is just open label, my opinion on it.
And that ties in nicely, Richard, with your experience with when the IIH is over, then they have the chronic migraine headache, and we just go to our armamentarium of usual migraine treatments. So do you have anything to add?
No. I mean, I think it's the same story again, that, we treat them with what we've got available, and the migraine treatments often work to a degree, but less well than they do for people with ordinary migraine. So I think, but it's a bit like, the new daily persistent headache, as Shuu-Jiun has said, that all of these patients, it's very refractory, it's very difficult to get any treatment, but that doesn't mean that you don't try. And, you have to try treating them, and you have to work your way through some treatments, and a percentage of these patients do respond to one or other of the treatments, and I have to say I'm very grateful if that happens. So I think one has to be realistic and say that, look, it may be difficult to get a response, but that's the way that we go about it.
And there's a final question from Henry. It's to Dr. Wang. He would like to ask Prof. Wang if we should wait for the clinical entity of NDPH until up to 3 months, as the IHC3 suggests.
Because if shorter than 3 months, I would always say that's an acute headache. I cannot diagnose with new daily persistent headache. In fact, I still consider 3 months probably not that new daily persistent. I would like to say probably 6 months. Then we will have a more homogeneous group, like they more intractable to be treated, in my opinion. But ICHD they are correct, because 3 months is enough for the patients.
Okay, now we have covered all the questions, and it's the time to wrap up this meeting. Thank you, all the participants for the active participation, and thank you, Bronwyn, Richard, Shuu-Jiun, and Henrik, for your dedication. And I would love to share some slides for promotion to about the upcoming event, but I'm in trouble with sharing. Sorry. I found it. Yeah. So you can see this slide. The IHS Educational Committee is planning a next webinar on post-traumatic headache. It will be on the December 1st at 8 p.m. London time. Dr. Jeffrey Kutcher and Dr. Montes will deliver brilliant talk about management of sport concussion-related headache and update on post-traumatic headache. And we are looking for the next International Headache Congress. This will be the first in-person Congress after 4 years of COVID-19. It will be held in Seoul, South Korea from 14th to 17th September 2023. So please save the date. As one of the scientific committee members, I believe that the next year's IHC is full of exciting programs. And you can refer to the program here. And we have probably the most diverse speakers ever. There are several opportunities for abstract presentation, so please participate. And I'm sure you will like Seoul. The venue is COEX Exhibition and Congress Center, which is located in central Gangnam district. So you can enjoy the modern vibes of Gangnam. We expect you can enjoy latest research and update, meet with industry partners that have networking opportunities and chance to present your work. So see you everyone in person in Seoul next year. This will conclude today's webinar. Thank you again. Have a great rest of your day. Bye-bye.